Good morning, good afternoon, and good evening, everyone. I am Rikile Kierkegaard, the program specialist on knowledge management and learning in the HIV and AIDS section at UNICEF headquarters in New York. I'm very pleased to welcome you all to this webinar, which will be bringing you updates on children, adolescents, and HIV from the International AIDS Society 2019 conference. I'm very honored to open this webinar, which will be presented by the highly esteemed Dr. Lynne Mofenson. Dr. Mofenson is currently working as Senior HIV Technical Advisor at the Elizabeth Glaser Pediatric AIDS Foundation. She was at the National Institutes of Health from 1989 until her retirement in 2014, where she was responsible for program planning and the development and scientific direction of research studies and clinical trials in domestic and international pediatric, adolescent, and maternal HIV infection. UNICEF's Learning Collaborative has been working with Dr. Mofenson on several scientific webinars in the past, and we're very pleased that she has agreed to host and curate this webinar once again today. As mentioned, it will be bringing you a scientific summary of the latest evidence which was presented at the International AIDS Society conference on HIV Science, as well as the annual international workshop on HIV Pediatrics, which were both held in Mexico City from the 19th to 27th of July, 2019. The presentation will take around 1 hour, followed by 25 minutes for Q&A. Before we get started, I would like to mention a few words and guidelines about the webinar. First of all, if you have any trouble hearing or have other technical issues, please do send us a message via the chat box and we'll try to support as much as possible. Before writing us, do try and log out and log in or restart your computer. Use of headphones generally provides a better audio experience, and please do keep your mics on mute so we avoid any background noise. Finally, if you have any questions occurring to you during the presentation, please type them immediately using the chat feature, but we will only be taking the questions during the Q&A period. This webinar is being recorded, and the recording and all materials will be made available online after the webinar on childrenaids.org. So please do help share this recording with any of your colleagues that may not have been able to join us today. So without further ado, I'll hand over the floor to Dr. Lynne Mofenson.
Hi, everybody. Let me just get my slides up here. So do we have the slides up okay?
Yes.
Okay, good. So, hi, everybody. I'm going to go over some of the data that was presented at the Pediatric Workshop and the International AIDS Conference just last month. So what I want to start with is the update that was provided by UNAIDS and WHO on the epidemiology of pediatric HIV in 2018. So to open the pediatric workshop, Mary Mahey went over the latest spectrum data. And this slide shows you the number of new child infections by year from 2000 to 2018. And there's been a 63% decline since 2000. However, progress has stalled, and there's been only an 8% decline in the past 2 years, with 160,000 new infections in 2018, which is very far from our 2018 target of 40,000. This slide shows you the number of children living with HIV by age, with blue shown in 0 to 4, 5 to 9 shown in orange, and 10 to 14 in gray. And what you can see is the growing proportion of children in the older age group, 10 to 14 years, with perinatal HIV. This slide shows you the number of new infections among young women and young men in 23 focus countries from 2010 to 2018. And you can see there's been a decline in new infections among both young women and young men, but there's still a significant gap, with the number of new infections in young women being around 400,000 compared to young men about 200,000. This slide shows you AIDS-related deaths among children globally. This is from children from 0 to 14. And you can see that there's been a decline. But again, like new infections, this decline has slowed, and there were still 100,000 new deaths in 2018. And if we look at AIDS-related deaths among children and youth, showing the 5 to 9 year in blue, 10 to 14 in orange, and 15 to 19 in gray, you can see while there's been a decline in the other age groups, for the 15 to 19-year-old age group, there's really been no decline, and the graph is pretty static. This slide shows global ART coverage for children. Globally, 54% of children who are living with HIV are receiving treatment, but this compares with 62% among adults and 82% among pregnant women. And if we look, we can see that there's high variation globally, with extremely low coverage in West to Central Africa. Only 28% of children are receiving treatment there. So we need new modalities to identify children with HIV. So the green line here shows you the number of children receiving treatment globally, while the orange line is in focus countries, and the orange dot shows you the global targets. And you can see we've clearly failed to meet the 2018 target of 1.6 million children, and we're way off the lowered target of 1.4 million by 2020. This slide shows you the treatment cascade for children. So in blue, you see knowing your status. In orange is receiving treatment. And in gray is whether the viral load is suppressed. And the yellow shows you the FIA survey data when it's available. And this is in 11 countries. And you can see that viral suppression in children on treatment ranges from 25 to 65%, and 6 of 11 countries have viral suppression rates for children that are less than 50%. And this was shown even better in a presentation done at the Pediatric workshop, looking at FIA data for 10 countries in children, looking at viral suppression from 2016 to 2018. And you can see while there was variation between countries, the pooled viral load suppression data was only 37%. And this was contrasted to adults, now shown in green, age 15 to 49, with the pooled viral suppression rate in children being 37% compared to 57% in adults. And if we look at 90-90-90 for children 0 to 14 compared to adults 15 to 49, you can see that the number of children who know their status is 10% lower than in adults, but even more striking is the difference in the rate of viral suppression. So why is viral suppression so poor? Is it because we lack potent drugs for children, because there's delays in obtaining appropriate dosing? Is it a delay in transitioning children from older drugs to better new drugs? Is it a lack of appropriate formulations for young children because they're dependent on adult administration? Or potentially is this due to drug resistance? And at the conference, Silvia Bertagno presented data on the prevalence of pretreatment drug resistance, PDR, in infants through the WHO surveys of infants less than 18 months old. And this looks at NNRTI, pretreatment drug resistance. And you can see that the rates range from 35% in Eswatini to nearly 70% in Malawi. And 1 out of 2 newly diagnosed infants with HIV have efavirenz or nevirapine resistance. So those are clearly not good drugs to choose for initial therapy for such children. This slide looks at the prevalence of NRTI drug resistance, with blue showing you any NRTI, purple is bacavir, green is 3TC or FTC, red is AZT, and yellow is tenofovir. And the rates are not as high as we see with NNRTI, but still in some countries high. So for any NRTI, it ranges from 2 to 23%. For abacavir, from about 2 to 18%, XTC 2 to 16%, AZT 1 to 12%, and tenofovir remains low, but in some countries, 7%, it's approaching that 10% place of concern. So what has been the response of countries with high pretreatment drug resistance to NNRTI in infants? And this shows you a number of countries with high levels of pretreatment resistance. And what I just want to point out is that in many of these countries, despite the high levels of resistance, going towards 70%, NNRTIs are still commonly used first-line treatment regimens. And we just at the Elizabeth Glaser Pediatric AIDS Foundation did a study in Eswatini that was looking at family-based care. And in that study, we found that about 50% of children, all the children were on treatment, which was great, but 50% of the children were receiving nevirapine-based treatment. They'd never been switched from when they were young and started on nevirapine to better drugs, and that nevirapine-based treatment was associated with lower levels of viral suppression than seen in children on efavirenz or lopinavir. So for this section, in summary, while progress has been made for PMTCT, it has significantly stalled in the last few years, raising the question of how do we reach this last mile to elimination of mother-to-child transmission. What we have is that we've done the easy part of the work, but the harder part of the work remains. There's a slowing decline in AIDS-related mortality in children. Is this because global treatment coverage is only 54% and there's lower rates of viral suppression than in adults? The data show us that adolescents are a key target population, and we see there's an increasing age of youth living with perinatal HIV globally, and that these youth have poor viral suppression, which raises the question about increased risk of transmission to others as they reach their sexual debut. Young women remain at higher risk of HIV than young men, and AIDS-related mortality hasn't declined among youth, so this is clearly an important target. And there are very high rates of pretreatment drug resistance among newly infected infants, yet use of NNRTI-based first-line treatment remains common and may contribute to the poor viral suppression that we're seeing in children. So we're now going to move, and there was a lot of new data on dolutegravir and pregnancy outcome, including neural tube defects that I will discuss. But before we discuss this, I wanted to give some perspective on neural tube defect risk. So there are a number of different risk factors that we know are proven to be associated with the risk of neural tube defects. And inadequate folate is one of them. So if maternal red cell folate is less than 500, there's a four-fold increased risk of neural tube defects compared to when it's over 1,000. Maternal diabetes, maternal obesity, maternal hyperthermia are all associated with increased risk of neural tube defects, around average of about a threefold increase. And then valproic acid is known to be associated with NTD, and here we see a tenfold increase. So this shows you data from the Botswana Tasambo study on neural tube defect prevalence in May 2018. And at that time, they reported 4 neural tube defects out of 426 preconception dolutegravir exposures, giving us a rate of 0.94%. And this contrasted with rates with non-dolutegravir given preconception over 11,000 exposures with a rate of 0.12. The subset using efavirenz preconception, the rate was 0.05, and HIV uninfected women, where in over 66,000 exposures, the rate was 0.09. So there was a significant prevalence difference between preconception dolutegravir and all other exposure groups, ranging from about 0.8 to 0.9. And this shows you the evolution of neural tube defect prevalence over time in that Botswana study. Rebecca Zash presented this both at the Pediatric Workshop and the International AIDS Society, but also the article was published in July 22nd, New England Journal of Medicine, that you can get online. And you can see that we've quadrupled the number of exposures with dolutegravir preconception from 426 to 1683, and happily the prevalence has gone down from 0.94 to 0.3. But we can see for all other exposure groups, the prevalence has basically remained the same. The lines are straight, with non-dolutegravir preconception 0.11, efavirenz preconception 0.04, HIV uninfected 0.08. And this is still significantly different prevalence with dolutegravir preconception than all other groups. It's about 0.2 to 0.25. So while neural tube prevalence has decreased with increased exposure numbers, it still remains significantly different from other comparison categories. And it's possible that a larger number of exposures are needed to see resolution of the signal, because to detect a threefold increase in risk with a prevalence of a defect with a prevalence of 0.1%, you need about 2,000 exposures, or it's possible that the elevated risk will remain at this lower level. Rebecca also presented data on other pregnancy outcomes comparing preconception dolutegravir to preconception efavirenz. So on the left, you see data that were published in 2018, and this is looking at efavirenz versus dolutegravir started during pregnancy, and you can see the curves are basically the same for both, for any adverse outcome, serious outcome, and all of the subcategories. And she presented data at the meeting looking at efavirenz or dolutegravir started before conception, with the rates being very similar. One exception is the rate of stillbirth did appear to be a little bit higher with dolutegravir preconception than efavirenz preconception, but this was not statistically significantly different. So also presented at this meeting were data from the Ministry of Health of Botswana, who worked with the CDC to add an additional 22 delivery sites in Botswana that were not part of the Sipambo study for additional birth surveillance. And together with the other study, they covered about 92% of all births in the country. And so they presented data on their surveillance from October 2018 through March 2019. And this is a similar figure. They saw one neural tube defect out of 152 preconception dolutegravir exposures for a rate of 0.66, compared to no neural tube defects in over 500 other exposures, and 2 neural tube defects with a little bit over 2,000 exposures for HIV uninfected women. None of these were statistically significantly different, but if we then compare this to the Sipambo data, we see that the data for the non-dolutegravir groups are very similar. And the dolutegravir at conception group has confidence intervals that overlap the 0.66 seen by the Ministry of Health data. So these are relatively confirmatory of the Sipambo study. There were data from Brazil. A case control study was presented. They used registry linkage through national Ministry of Health databases to estimate NTD risk with periconception dolutegravir compared to non-dolutegravir treatment, either efavirenz or raltegravir. And they found no neural tube defects at all in any groups with periconception treatment looking at live births. They did not necessarily look at defects in stillbirths and abortions, because this is a retrospective study here. So you can see there were over 1,000 non-dolutegravir periconception exposures, 384 periconception dolutegravir exposures with no neural tube defects. But you also note that the rate of spontaneous miscarriage was higher with periconception dolutegravir, 6%, compared to periconception non-dolutegravir, 2.6%. And I just point out that the neural tube defect prevalence in Brazil, where there is folate food fortification, is 0.06%. So if the threefold increase we saw in Botswana is correct, a threefold increase to 0.18% is likely not going to be detectable with only 384 exposures. I presented data from the Antiretroviral Pregnancy Registry looking at over 20,000 prospectively enrolled pregnancies through January 2019, and we looked overall and by drug class and by specific drug, assigning an earliest timing of exposure to each drug, either periconception, which is defined as 2 weeks before conception through 28 days after conception, or 6 weeks estimated gestational age, later first trimester, and second and third trimester. Overall, there were 536 defects that included 8 neural tube defects for a prevalence of 0.04% and 1 encephalocele, but we're going to focus on the 8,546 periconception exposures where we have 3 neural tube defects. And this chart shows you by drug class and specific drug. So as I said, there were 3 neural tube defects out of 8,546 exposures for a prevalence of 0.03. For the NRTI drugs, it was 3 out of about 8,000 for a prevalence of 0.04 and was distributed across the different drugs. For protease inhibitors, 1 out of 3,830 for a prevalence of 0.03%, and this was with atazanavir. For NNRTIs, this was with efavirenz, the prevalence was 0.04%. And then for the integrase inhibitors, now with the January 2019 data, we now have 1 neural tube defect out of 725 periconception exposures for an overall rate of 0.14, and that was with dolutegravir. It was the case of anencephaly in a stillbirth from the U.S., and that's 1 out of 248 for a prevalence of 0.4%. Now, most APR reports come from North America, where there is national food fortification, which reduces NTD risk. The overall prevalence for all antiretrovirals was 0.03, which is very consistent with the observed low prevalence in most developed countries, including North America, with food fortification. But we now have in the updated data 1 neural tube defect with the 248 periconception dolutegravir exposures, giving us a prevalence for dolutegravir and for the integrase inhibitors that's higher than all of the other classes, but this is based on only 1 NTD in a relatively small number of exposures. So the number of pregnancies currently enrolled in the APR with periconception integrase inhibitor exposure are really insufficient to rule out or to confirm a potential association with NTD. So this slide shows you a review that was presented of all of the available data on neural tube defects with preconception dolutegravir, both published and unpublished data. And it is divided by whether or not there is national folate food fortification, yes or no, and that's because food fortification changes the background rate of NTD. And so if we look first at countries without food folate fortification, so this includes Botswana, the prevalence of neural tube defects was 6 out of 2,031, giving you a weighted estimate of 0.36%, ranging from 0.1 to 0.62. So in countries without food folate fortification, the pooled prevalence in the general population is about 0.09 to 0.1. So this gives us about a 3.6 to 4-fold increase. In countries with food folate fortification, we have the 1 neural tube defect from the pregnancy registry out of 901 exposures, giving a weighted estimate of 0.12. And in the general population in such countries, the pooled prevalence is 0.06%, So this now gives us about a twofold increase. So I just wanted to point out the countries with food folate fortification. So all of the countries that have colors have national mandatory food fortification, and the colors just simply show you what kind of food. For example, red shows wheat, green shows wheat and maize, etc. And there's a 40 to 66% decrease in neural tube defects in countries with food folate fortification. And if we look at the prevalence of HIV and compare that to countries where there's food fortification, you can see many of the countries with the heaviest burden of HIV, Africa, Eastern Europe, and Asia, have no food folate fortification policies. So while the protective effect of folate in women on dolutegravir who wish to become pregnant is not yet established, we would just wanted to point out that folate food fortification improves pregnancy outcomes in the overall population, and that perhaps countries that don't have such policies might consider them. This shows you the recommendations from WHO that were updated at the meeting. And this shows you the 2018 recommendations, where dolutegravir was recommended as the preferred first-line regimen for everyone, but adults and adolescents were distinguished from women and adolescent girls of childbearing potential, with a note of caution about the use of dolutegravir. So in 2019, based on much of the data that you've seen and some additional data, dolutegravir is now recommended for all adults and adolescents without distinguishing by gender as a strong recommendation. And efavirenz was also recommended as a low-dose alternative, efavirenz 400. And rather than having a note of caution, the guidelines now say that women should be provided with information about benefits and risks to make an informed choice about the use of dolutegravir or other treatment. And one of the things I'm not showing you are two risk-benefit analyses that were conducted that are also published, Andrew Phillips in Lancet and Kate Dugdale in Annals of Internal Medicine, both that showed that the use of dolutegravir in women of childbearing potential, the benefits outweigh the risks. So in summary, the preconception dolutegravir NTD signal, while significantly diminished, remains significantly different than in all other exposure groups, and this is validated by the Botswana Ministry of Health and APR data. Now, it remains possible that with additional exposures, the signal may resolve in Botswana, but it's also possible that it may remain at this threefold increase, which is similar to the association with folate deficiency and maternal diabetes and obesity. Other adverse pregnancy outcomes do not appear to be different between preconception dolutegravir and efavirenz, and WHO now recommends dolutegravir as the preferred first and second line for all adults and children who have dosing information as a strong recommendation. So moving on to other data from pregnancy, et cetera. These are data from the ECHO trial. The ECHO trial randomized HIV uninfected women to three different forms of contraception, DMPA, LN implant, or copper IUD. This was published in Lancet, showed no difference in HIV incidence by the kind of contraception. But this study that was presented at IAS compared pregnancy incidence. They had 255 pregnancies, with the vast majority occurring after the contraceptive method was stopped. And what they found was that all contraceptives were highly effective, with the pregnancy incidence ranging from 0.61 to about 1%. And this compares to a pregnancy incidence in South Africa that's 25% per year. There's a slightly higher rate with IUDs, and this may be due to asymptomatic, partial, or complete expulsion between visits, and they noted that people receiving IUDs should be evaluated for this. This is data from Zambia that looked at the levels of viral suppression using low-dose efavirenz 400 milligrams. And they looked at 287 mother-infant pairs with 271 of the women transitioned to efavirenz 400 during pregnancy, and 16 remaining on efavirenz 600. The majority of women started treatment during pregnancy, with 41% receiving treatment at conception. And the important thing here is that maternal viral suppression at delivery was 92% among those getting efavirenz 400, 88% among those receiving efavirenz 600, so very similar between the two. So efavirenz 400 can be used in pregnancy. In utero transmission was found in 0.7% of the exposed infants, so relatively low rate of transmission. These are data from Botswana. This is from an early infant treatment study where they are testing HIV-exposed children at less than 96 hours, tested over 10,000, had 40 that were HIV positive, and they were able to link to the Tasambo database to get information on maternal treatment to look at in utero infection between dolutegravir or efavirenz treatment. And they found no difference in the rate of in utero transmission. It was 0.65% with dolutegravir, 0.37% with efavirenz. And they also looked at it broken down by when the treatment was started during pregnancy. And in the red box, you can see that the highest rate of transmission in both dolutegravir and efavirenz arms was when antiretroviral therapy was initiated late, less than 30 days before delivery. So late initiation is the most important factor here. This data looked at viral load in women at delivery from 4 obstetric units in South Africa, where they were offering point-of-care infant diagnosis and point-of-care viral load at delivery. They had 8,000 live births to HIV-positive women. They had valid viral load results on 2,700, so only 34% actually had a viral load done. And what you can see is that viral load was greater than 50 in 36% of these women on treatment. And of those with viral load greater than 50, 32% were between 50 and 399, 10% were 400 to 999, and 62% had viral load greater than 1,000, so 22% overall, with the median viral load of about 24,600 copies per ml. Despite the viral load, however, the PCR positivity at birth was relatively low, 1.5%. This is higher than we saw with dolutegravir and efavirenz in the previous study, but still pretty low. This study looked at adverse pregnancy outcomes, wondering whether women with HIV who are on treatment are now have adverse outcomes that are similar to those seen in HIV uninfected women. And these are data from Lesotho from a prospective cohort that was looking at a facility-based intervention to improve antenatal care. And it included 614 women living with HIV and 390 HIV uninfected women. All the HIV positive women were receiving treatment, most efavirenz, and had delivery outcomes for the vast majority. And this shows you the type of adverse pregnancy outcome and the rates in HIV uninfected and HIV positive women. So if you look at composite, any adverse outcome, intrauterine fetal loss, preterm low birth weight, or birth defect, there was a significant difference, 20% in women living with HIV, 11% in HIV negative. And if you look at the individual categories, you can see for intrauterine death and for low birth weight, this remains statistically significant, whereas for birth defects and prematurity, it was not. In a multivariate analysis, these findings remain statistically significant. This analysis adjusted for maternal age, gestational age at enrollment, gravidity, and education. And in a subset that had syphilis testing available, again, you see that this remains statistically significant for the composite outcome, intrauterine loss, and low birth weight. Among the women who were HIV positive, there was not a difference in adverse outcome by timing of treatment, whether they started preconception or during pregnancy. So these are a similar type of data from Blantyre, Malawi, using a registry from a tertiary hospital and its primary care facilities, looking at about 14,000 women. 12% were HIV positive, having very similar types of findings, comparing HIV uninfected and HIV infected. There was a 1.5-fold increased risk of low birth weight, a 1.2-fold increased risk of preterm. But interestingly, when they looked by delivery setting, in low-risk women, they looked very similar to HIV uninfected women, but in high-risk women, the rates were significantly elevated. Now we're going to move to Zimbabwe, that has begun routine case reporting for all new HIV infections in young children. And they do an analysis of each case to look at missed opportunities. Whoops, sorry about that. So looking at antenatal service uptake by mothers who had infected infants, 10% of mothers of HIV-positive infants had not booked for antenatal care, whereas national coverage is 94%. And there was a significant association in women who lacked antenatal care with home delivery, not giving infant prophylaxis, and if the infant was positive, not receiving treatment. This looks at the timing of maternal diagnosis. Only 23% of mothers who had an infected infant knew their HIV status before current pregnancy. That's in blue. 26% first tested for HIV in labor and delivery or postnatal. That's in red. And 28% were either not documented or not tested. And this looks at the time on treatment for the mothers of infants who were infected, and the vast majority had inadequate antiretroviral treatment, either starting treatment less than 8 weeks before delivery or post-delivery, or stopping treatment or never having treatment, and 80% didn't have viral load testing. So this helps the country know what is causing their new HIV-infected infants and shows us the role of late diagnosis, limited time on treatment, and lack of viral load testing as primary risk factors. So in summary, contraception of various modalities is highly effective and safe in women in Africa. The main factor associated with in utero transmission is not the type of regimen, but the time of initiation of treatment, with late initiation, especially less than 4 weeks before delivery, associated with a significant increase in transmission. While treatment is effective in pregnancy, a significant proportion of women may lack suppression at delivery, although in utero rates, thankfully, remain low. Despite treatment, women with HIV appear to have increased adverse pregnancy outcomes compared to women without HIV, and we need to be able to figure out why that is. And then finally, a missed opportunity analysis of cases of perinatal transmission are very useful in determining where the gaps are in the PMT-CT cascade in the country or even sub-nationally. Moving on to treatment in children. The first study is from the Odyssey study, which is a randomized clinical trial in children evaluating the efficacy and safety of first and second line dolutegravir in over 700 children, and they're doing a sub-study there in younger children to look at pharmacokinetics of the dispersible tablet of dolutegravir, which is not yet available, and you can see the dosing for that in the table. And they focused on the 6 to 20 kilogram group. And this shows you the WHO weight band, the pharmacokinetic data, and in the white you see the reference in adults. So the first thing that you can see is that the trough looks good, except in the youngest infants, 6 to less than 10 grams, where the trough levels were below the value that we want to see it in 36%. In the other children, it was similar to adults. The area under the curve was similar to the adults. And the peak levels were somewhat higher than in adults in the higher weight bands in children. So it was felt that this helped to define the dose for 10 to 20 kilograms in the dispersible tablet, which will hopefully be available soon. And they're going to do some further evaluation in the 6 to 10 kilogram, and data in the kids less than 6 months, less than 3 months is ongoing. So this goes over the WHO recommendations in 2019 for children, which were not really different than the 2018 recommendations. And they focused on simplification, moving away from NNRTIs, introducing dolutegravir, and using the most potent NNRTI option. So they introduced an indeterminate range for infant diagnosis, introduced birth testing. This is the same as last year. And the preferred regimens for children are integrase inhibitors, both for neonates and for infants and children. For neonates less than 28 days, raltegravir is the integrase inhibitor until we get data on dosing for dolutegravir. And for infants and children, it is dolutegravir. Additionally, they talked about transition. I talked a little bit about Eswatini, where all of the kids were still on nevirapine. And so they talked about the goals of transition being to improve outcomes, to harmonize, simplification, and to ensure that you have a supply chain security, and that children who would be eligible for transition are kids who are already on treatment, completely clinically stable, and that children on NNRTIs should be prioritized, particularly the kids on nevirapine. And this box shows you the types of recommendations. All kids over 20 kilograms should be moved to dolutegravir, either with the bacavir 3TC for the younger kids or to TLD, tenofovir 3TC, and dolutegravir for the kids over 30 kilograms. And kids on nevirapine should move to lopinavir. This study looked at the safety and efficacy of elvitegravir, cobicistat, FTC, and TAF in virally suppressed children. It was a switch study in children who were 6 to 12 years and over 25 kilograms who were stable and suppressed and switched to ECF-TAF. And the pharmacokinetics were consistent with prior studies in adults, and most important was that viral efficacy was maintained, with 98% of kids maintaining viral efficacy out at a year. They had no grade 3 or higher AEs or serious AEs or anything leading to drug discontinuation. And shown is the bone mineral density adjusted Z-scores, which remained stable, and this contrasts with what you see with tenofovir. And this study looked at drug resistance mutations in children who were failing treatment. This is kids 10 to 24 with viral failure on first or second line who are enrolled in a peer support intervention. And 86% of these kids had one or more drug-resistant mutations, 60% to NRTIs, 85% to NNRTIs, 10% to PIs. Dual resistance to NRTIs and NNRTIs were detected in 60% of first-line failures. PI resistance was uncommon. It was about 10% in second-line failures. And so this raised the issue that the switch of first-line failures, as opposed to transitioning kids who are stable to dolutegravir, but kids who have viral failure, could be problematic given the extent of resistance mutations. And the author of the study recommended that drug resistance data is needed to better inform strategies for implementing a switch to dolutegravir for kids who are failing. And finally, this looks at the TB treatment cascade in children with HIV from 7 Baylor Centers of Excellence in 6 countries. And 96% completed screening, 58% had a positive screen, 41% with a positive screen were classified as presumptive TB, which was confirmed in 27%. TB treatment was started in 84%, which sounds good until you realize that 16% with TB didn't start treatment, and 74% completed treatment or were cured, which means that 26% didn't complete treatment, even in centers of excellence. So the summary for this section is that dolutegravir is recommended as preferred first line for all children over 20 kilos. Dosing for younger age groups and lower weight bands is underway, and a dispersible tablet formulation may be available in the near future. ECF-TAF appears safe and effective for older children, and that drug resistance mutations are frequent in children failing first-line treatment, which may complicate transition to more optimal regions. And we need a lot more work in the TB cascade like we do in the 90-90-90 cascade for HIV in children, because it remains suboptimal. So moving on to adolescents and HIV. This looks now, taking the same echo trial that we talked about before, looking at HIV incidence in women who are uninfected and randomized to one of these modes of contraception. And this analysis focused on 5,700 women enrolled in South Africa with a median age of 23 years, with 63% less than 24 years. And they found an incidence of 4% per year, 4.51 per 100 women years. And the incidence was greater than 3% at all of the sites participating in the study. Age less than 24 years, baseline sexually transmitted infection, BMI less than 30, and multiple new partners were associated with HIV acquisition. This data looks at recent infection surveillance in Malawi. They compared two different types of tests of recent infection. And they found on the left here, you see the recent infection results in the males by age group, and on the right you see recent infections in females, and the little orange triangle is the recent infections. And the first thing you can see is that the girls with the highest rate of recent infections were younger than the boys, 13 to 19 compared to 20 to 24 years. And recent infections occurred in about 1 in every 5 infections diagnosed in males, 20 to 24, and in females, 13 to 19. And this looks at recent infections by point of service, and they found the highest rate of recent infections in the inpatient clinic, in the ANC clinic, and the dermatology clinic, followed by VCT and STI clinics. And this looks at recent infections surveillance in Malawi, focusing on pregnant adolescent girls and young women. So it was a cross-sectional estimate of recent infection in girls attending their first ANC visit. So they found overall about 12% of all infections were recent, so about 1 in every 10 newly diagnosed pregnant adolescent was recently infected, with a difference between districts, indicating that adolescent girls are not being tested frequently or early enough. And then this looked at a variety of different factors. The overall annual incidence was 0.59%. It was higher among girls 20 to 24 than 15 to 24, and as I noted, differed by district, so one can look nationally to see where is the highest risk area. This looked at predictors of HIV incidence in adolescent girls in Malawi. It was a prospective cohort of sexually active adolescent girls, and it looked at different risk factors and correlated this with HIV infection. They had a total incidence of 2%, 2.08 per 100 person years, and had a risk tool with 4 variables that had 5 points, so vaginal discharge, genital ulcer, ever pregnant, or an older partner over 5 years, and found that a score on this risk tool of 3 or more had an HIV incidence of 5.88, so almost 6% per year, with a sensitivity of 64%, a specificity of 76%, helping you assess who is at greater risk of HIV. This study looked at financial incentives to try to reduce this high HIV incidence among adolescent girls and young women. So from November 2015 to March 2016 in Eswatini, they enrolled over 4,300 adolescent girls and young women in 266 non-overlapping areas, the little red and blue dots shown in the map. And they stratified enrollment by whether they were in or out of school and rural or urban. And they had a 2-by-2 factorial design where they looked at an education incentive only, a raffle incentive only, both or none. So the education incentive included paying for enrolling and attending school or paying for enrolling and completing other education, about $100 a year. And in 2018, they added tuition fees paid for out-of-school participants. And the raffle incentive, well, they had about 50% of the participants were randomly selected for the raffle. At each raffle round, 400 were selected for STI testing, and if they were negative for syphilis or trichomonas, they were eligible for a raffle prize, and they gave 8 raffle prizes every round for 7 rounds, with a prize being about $72. And this just shows you enrollment. So there was about 2,200 in each arm, and then they were randomized to the education plus raffle, education alone, raffle alone, or no intervention. And this just shows you their timeline. They held their 7 raffle interventions over the course of 3 years, and the education incentives were matched up with trimester of school. So 52% of kids received the education incentive for enrolling in school, 31% for out of school, and 19% got prizes. And their analysis was based on 3-year HIV incidence, which they had data on 86% of these children enrolled. So first, looking at the education incentive. So we're comparing the education arm to the no education control arm. So that's people who got nothing or who only got the raffle. And they found that HIV incidence was decreased by 23% with education versus no education over a 3-year period of the study, 8.1% without education, 6.3% with 3-year incidence. The raffle intervention appeared to have no effect by itself. And then when they looked at their 2-by-2 factorial, they found that, that both the education and raffle together provided the best HIV incidence reduction with a 37% reduction. So 8.8% 3-year incidence with no intervention, 5.8% with education and raffle. So to get a yearly incidence, you have to divide these by 3. This looked at the number of incentive patients and the rate of incidence, and showed that for each additional round of education incentive received, the HIV incidence over 3 years was reduced by 3.9 percentage points. So keeping kids in school longer had a better effect. And then they looked at the profile of participants and their risk of acquisition of HIV, and found that being out of school or making more risky decisions increased risk, and higher levels of education and less poverty decreased risk. And then there was a very nice presentation that looked at what lessons were learned by a project that was targeting young people at risk, Project PrEP, which was done in South Africa, attempting to integrate PrEP into comprehensive reproductive and sexual health services in 3 provinces in South Africa. And they used a pretty intensive implementation model. They had a hotspot mapping first, and they had a mix of clinic and mobile van outreach. So they had fixed facility clinics, 2 fixed facility clinics with a mobile unit that went between these clinics, reaching surrounding areas. They used existing nurses with capacity building and mentorship. They facilitated getting youth-friendly services. They had this roving unit, as I discussed, enhanced monitoring, and a biometric system to monitor the youth. And they had a clinical package that was much more than just PrEP, with many services rendered through the mobile van. You can see ranging from HIV testing to syndromic STI diagnosis, PrEP, TB screening, pregnancy tests, contraception, counseling, creatinine, adherence, and referral. And all of those services were rendered through the mobile van, with people went to the facility for more specific testing, such as laboratory STIs, hepatitis B screening, cervical cancer screening, etc. They noted that a menu of strategies was needed at each level. So they used a hotspot mapping to identify where their PrEP clients would be. They had their mobile unit that was able to go out to schools and reach their target group, and had extended working hours and visits on weekends. They used their mobile units to reach the kids at school, as I talked about. And they ensured continuity at the facility with a PrEP nurse always available and youth-friendly nurses. And found a combination of strategies were needed. So this looks at the number of clients receiving PrEP, and I'd like you to just focus on the blue line, which is 15 to 24 years. So you can see everybody's about the same until they integrated training of the clinics on integrating PrEP, and they began to map their hotspots, and you see this increase in the number of youth receiving PrEP. They activated their clinics with a big increase in the youth receiving PrEP. And then when schools closed, they had some problems here, and the number of initiations went down, and that's where their mobile clinics were very useful. As in other studies, they found that PrEP initiation was good, but retention and adherence was poor, and you can see by 3 months in green that we were down to 19 to 23%. Whoops. That a menu of options were needed to assist adherence. For example, long school holidays often made a break, and they needed to be able to provide PrEP that lasted during these holiday periods. And found a variety of different strategies used to retain PrEP clients, including using social media, frequent contact through telephones, and assisting the client with decision making. And they pointed out that adolescent girls need more than just PrEP. Their partners were generally older. A high proportion had been pregnant, treated for STIs. Very few had received preventive therapy with a pap smear or received HIV testing, and a significant proportion were depressed. And so they found that youth really needed more than just PrEP. You needed to integrate oral PrEP into other sexual and reproductive health services, ensure that nurses are trained, provide a mobile clinic, which was a one-stop shop service point, establish youth clinics that were youth-friendly, ensure consistent communication, mentorship of the nurses, and a strong referral network. This study came from IDEA South Africa that looked at youth, perinatal youth, and tried to say what did they look like when they were diagnosed and what do they look like now. So they had over 25,000 youths from Southern Africa, the countries shown on the map. Found that these youth at the time they were diagnosed and enrolled into care were already severely immune suppressed, and over 50% with low weight and stunting. And found that when they became 10, they were still pretty underweight and stunted. 89% were receiving NNRTI-based regimens. And of those that had a viral load measure, 78% were less than 400. And found 3% died, 16% transferred, 22% were lost to follow-up, 1 in every 5. And they concluded that children with perinatal HIV have suboptimal retention, viral suppression, and survival during adolescence, and that those initiating treatment at older ages and those immunosuppressed during adolescence need careful follow-up to optimize outcomes. This was data, now we're looking at PrEP use in young women. This was a study that was actually, excuse me, comparing using what they called standard adherence support, which doesn't seem so standard to me. A lot of weekly SMS, monthly adherence clubs saw them 1, 2, 4, 6, 9, 12 months, discrete pill containers, and standard adherence above, plus giving drug level feedback using a dried blood spot tenofovir levels. They had very good retention in both arms, high initial PrEP uptake, 95%, but as the previous study, adherence declined significantly after 3 months when they changed to quarterly visits. So started out with tenofovir being detectable in 84%, and by 12 months, this was only 30%. And they found no effect of the drug level feedback, but I do have to say that this was delayed feedback. They would draw the test, and then the drug levels would be discussed at the next visit as opposed to immediate feedback. But they found, similar levels of adherence in both groups. Correlates of high adherence include perceived risk of HIV, and they had a PrEP readiness score that they used. They had 4 seroconverters in this study, and all of them had either undetectable tenofovir or very low-level tenofovir detected. So their seroconversions were due to non-adherence. And they had an HIV incidence of only 1% per year, which is low considering the risk profile. And if we think back to that financial incentive study, the best they had was 5%. So this looks at PrEP adherence specifically at women initiating PrEP in maternal child health or family planning clinics in Kenya. They had 22% acceptance, 40% continuing at 1 month. And they also did tenofovir levels, but they selected women who reported that they were using PrEP. So their specific question was, if the woman's reporting that she's using PrEP, is she really using PrEP? And found that she was in general. From first follow-up visits, the frequency of detectable PrEP was 62%, later visits 90%, and the 1 seroconverter had no PrEP. And they found that PrEP adherence was more likely in older, non-pregnant women and highest in women with known HIV-positive partner. This looked at PrEP reinitiation after interruption. So this was a study in Kenya and South Africa where young women are offered PrEP, and they looked at patterns of PrEP use, and they found that PrEP uptake, as in all of the other studies, was initially high, that PrEP interruptions were common. 95% of the youth had some interruption. That PrEP reinitiation was found in 25%. So even though people interrupted, they did go back, and this may have to do with their perceived risk. And that PrEP interruption was often intentional. Women reported travel and relationship dissolution and sexual abstinence as reasons for interruption. So in summary for this section, there was a high incidence of HIV acquisition in young girls continuing to be documented with risk factors, as we've already known, STIs, pregnancy, older partners. That multi-component interventions are required for HIV prevention in young people. Financial incentives are effective in providing some decrease in incidence in one study, although a cost-effectiveness evaluation is currently underway. Adolescents with perinatal HIV are at particular risk and need special attention to retention, adherence, and suppression. And while high PrEP uptake is found with adolescent girls and young women, retention and adherence remains a problem, and additional and more support is needed. And I think, Ricky, I'll end there, and we can go to questions because I think I'm at 10 after.
Thank you very much, Lynne, for this excellent and very thorough summary of the latest research that's presented at IAS. We now have about 20 to 25 minutes for question and answer, and we will take all the questions from the chat box, so please do not hesitate to type in your answers now. Meanwhile, we have one question from the room here. Across all of this research presented, what were your sort of key takeaways in terms of the most promising future treatment and prevention developments for infants, children, adolescents? I know it's a big question, but like takeaways.
Well, I guess, you know, the dolutegravir issues were most important here. I think that we now have enough data to be able to say that while there may be a risk, it is low, that women can definitely receive dolutegravir. Hopefully we'll have dolutegravir dosing for children down to the neonatal area within the next year. So I thought that was all very important and exciting. I have to say that most of the other data were, while they were new studies, were not necessarily new information. You know, the fact that HIV positive women on treatment continue to have worse pregnancy outcomes than HIV uninfected women is been reported by others and really needs some further evaluation. What can we do to be able to bring this to back to levels like the general population? And just thinking, again, with youth, I felt like, well, we knew there was a high incidence. We know all of these informations. I think the emphasis on multi-component interventions was, I thought, important. The financial incentives were intriguing, although I'm not sure that whether they're cost effective or not, and that we have more work to do with PrEP. And then I guess finally, I thought that the Zimbabwe data on doing case evaluation to be able to figure out where the missed opportunities are in PMTCT was a good model for countries to take up.
Thanks again, very interesting insights. We now have two questions from the chat box. One is from Saeed Ahmed that is asking if you have any thoughts on how the recency results can translate into programming. And the other question is from Mike Arts and Lacro. Thank you for all the info provided. Were there any new insights in the area of infant feeding in the context of HIV?
So the recency results in programming. I find the recency results are most helpful in being able to identify high-risk groups to be able to target prevention to. So by knowing who are the people with most recent infection, you can be able to figure out who are the people that you should target most with prevention. The other thing that recency testing helps with is certainly in targeting partner notification activities and being able to bring in recent contacts for testing. So I guess those are some thoughts on programming. And infant feeding, there was not a lot on infant feeding. There was one study that I didn't present that talked about drug resistance, finding that that breastfed infants who become infected are likely to develop resistance to NNRTIs. No surprise, that's either the infants are receiving prophylaxis or the mothers are on efavirenz treatment and the infants are exposed to subtherapeutic levels in breast milk. But I don't think there was anything new that was discussed that I can think of that I attended at least.
Okay, thank you.
Mm-hmm.
Another Question from the room. Which are some barriers and recommendations or strategies for increasing and maintaining PrEP retention for adolescent girls and young women and their male partners?
Yeah, well, I think if we knew that, we would be golden. But I don't think we have that yet. I'm still a fan of the idea of being able to give feedback on tenofovir levels. I also believe that being able to give viral load data back right away would be helpful to people on treatment with adherence. So what they did in that one study was that they had this big delay. So they drew the tenofovir level and then they gave it back 1 month or 2 months later. It may be more effective if you had a point of care test that you could talk to the patient as they're there to be able to say, oh, your tenofovir levels are really good, you're taking your drug, that's good, or oh, your levels are low, and what can we do to help you? What are the problems? Similarly, I think with viral load, if you could have a point of care viral load and be able to talk to people while they're still, talking with you about, oh, your viral load's good or your viral load is bad, I think that those kind of immediate feedbacks would be helpful. Other than that, I think you end up with these complex multi-component interventions that they sound very good, but whether or not they can be systematically implemented in many countries is another question. But I think, a young person wants to be able to have services that are friendly to them. They, and having a mobile van that goes out to them as opposed to having them come in is something that appears to be very promising, but, countries have to invest in those things. I guess one other thing we didn't, because of time, we didn't go through the new drugs that I was going to present, and just a couple of comments on new exciting things. So there is a new drug, a NRTTI. It's a translocation inhibitor. It's a drug that has a very long half-life that they have put into an implant. And that implant appears to provide levels that can last as long as a year. So this is a very promising type of prevention intervention where you can put an implant in that can be taken out if there's toxicity. So that was, I thought, a very exciting new prevention intervention that was presented. 2 or 3 other new things. One is that the depivirine ring is in follow-up, and adherence appears to be much better than was in the trial. And this ring is going to the FDA relatively soon and may be available in countries within the next year or 2. The use of monoclonal antibodies is under study in women. And data from that study may be available within the next 1 to 2 years. And I think that was it. Yes. It looks like there's some more questions.
Yeah. Yes, we have several questions coming in. One is from Alistair. There seemed to be a lot on adherence to PrEP for young people, but there was not so much on adherence to ART for adolescents living with HIV. So just any thoughts on that?
Yeah,
please go ahead.
Yeah, I don't recall. There may have been, it's hard to attend every session, but certainly in the oral presentations, there wasn't anything on adherence to treatment. The question is whether there are similar things. I mean, adolescents, the kind of interventions that one would put in place for PrEP seem very similar to the kind of interventions one might put in place to enhance adherence.
Okay. Another question coming in from Deborah Jackson. Mentioning that much of these were results from randomized controlled trials, though some of the more promising areas you spoke about, such as the case review methods from Zimbabwe, are more in the implementation science field. Do you see any emerging role for implementation research?
Oh, absolutely. I think that research is critical, and it gets harder and harder to do randomized controlled trials. So I totally agree. There's an important role for implementation research.
Absolutely agree. Two more questions. One from Laura Broyles. In the presentation from South Africa on viral load in pregnant women at delivery using point-of-care viral load, only about 30% had a valid viral load results. Did the authors elaborate on why there were so few viral load results? And the second question coming from Malodi is, can we use the PrEP outcome data, the one that spoke about seroconversion and TDF level, as a demand creation strategy to encourage young people who are at risk of HIV acquisition to take and to stay on PrEP?
Yeah, so in the South African study, I think it was 34% had viral load results. So I think that was more related to the way that they did the study, which was that they did the study with the point of care testing for viral load during the weekdays and, a certain number of hours. And everybody knows women come in the middle of the night and on the weekend to deliver, so they missed all of those if they weren't doing the point of care testing at that time. So I think that's why they had such a low uptake. Although they didn't say that, they did talk about when they were doing the testing, and it was limited. And then the PrEP outcome data. So yeah, I think that it's important. I do continue to think that if you can give immediate feedback as opposed to delayed feedback, that this may be a better adherence intervention than the one that they tried.
Thank you again. Are there any other questions out there? No? Okay. If there are no further questions from the audience, we will close the Q&A. However, if you have any questions coming up, please don't hesitate to send them to me and we'll direct them to Lynne. This is the email address. Please note that we will post this PowerPoint and a recording of the webinar on the childrenandaids.org website. And as mentioned by Lynne, there is a longer version of these slides also on the website, where there's more information on PMTCT, on future ART drugs for women, on future PrEP options. So this was a condensed version to have it in a webinar. However, we have about 110 plus slides that will be posted online. So I would like to thank Dr. Lynne Mofenson once again for this excellent webinar and attention to all of the questions that were asked by the audience. So on behalf of UNICEF, I would like to thank all of you who took the time to join us on the webinar today. Remember to send the recording or the link to the recording to your colleagues that missed it. And we hope it will be useful to all of you in your work. So thank you very much and have a nice day.
Okay, bye-bye.
Bye.